Thank you so much all for your patience. Clarnet is India's largest live digital CME doctor-generated medical content platform. Our website is www.clarnet.com. We will invite all the doctors for visit our website. Now, without further delay, I would like to take this handover to Dr. Jitendra sir. Over to you, sir. Kindly proceed for your talk.
Thank you, Sneha. So, good evening, everyone who has joined today with us.
Yeah,
So,
good evening,
today's
Dr.
webinar
Jiten.
is on.
Yeah.
Yes, sir.
Yeah.
So, today's webinar on IgA nephropathy and IgA vasculitis. So, before we begin with webinar, we'll have the pre-webinar quiz. The link for the same quiz I'm sharing the chat box, so participant can click on this link and attempt this quiz. So we'll have 10 minutes of quiz. After that, we'll proceed with the webinar. So participants, please click on this quiz. This will take you to the Google form where you can attempt the quiz. So,
Yeah.
good evening, everyone, once again. Now I'll hand over the proceeding to moderator of today's session, Professor O.P. Misra. Over to you, sir.
Thank you, Dr. Jitan. So, well, friends, good evening to all of you. At the outset, I express my sincere thanks to ISPN Executive Committee and the President, Dr. Susan Uthop, and Secretary, Dr. Aditi Sinha, to provide me this opportunity uh, to join the webinar as panelist. Today's speaker is Professor Mukta Mantan, Head Department of Division of Pediatric Nephrology, Maulana Azad Medical College, New Delhi. And she is also one of the senior pediatric nephrologists of the country. And Dr. Mukta has served the humanity, especially during the COVID-19 period when she provided patients with renal diseases, especially RRT, to both children and adults in the NCR and Delhi at her college, and served a lot. And next case scenario presentation shall be done by the Dr. Radhika Radhakrishnan, Assistant Professor, Department of Pediatric Nephrology, SAT Medical College, GMC, Thiruvananthapuram. So, Dr. Mukta, are you connected?
Yes, sir, I am there. Am I
Yeah.
audible?
Yeah, you are audible.
Okay, thank
So
you, sir.
now I request you to start your talk on the common topic, IgA nephropathy and IgA vasculitis. We do see such children in clinical practice, and sometimes there is diagnostic dilemma as well as therapeutic challenge to us also. So now welcome to this webinar series, Professor Mukta, and now you can start your
Is
talk.
my screen visible, sir?
Yeah.
Thank you, sir. Thank you for a very kind introduction. And at the outset, I would also like to thank ISPN and the organizers of Team NEfPRO for giving me this opportunity to link to all the pediatric residents through these webinar modules, which are primarily directed towards the pediatric residents. And today I'll be talking about a topic which is relatively uncommon in the pediatric age group, but we all know that IgA nephropathy is the most commonly detected glomerulonephritis amongst the adults. And on the other hand, but it is less common in the pediatric age group, whereas IgA vasculitis is one of the most common vasculitis that we see in the pediatric age group. And the etiopathogenesis of both these conditions is linked closely to IgA. So that is why they are held together. So I'll be talking to you about both these conditions in briefly. So if we go to the historical background of these two conditions.
Sorry to interrupt you. We can't see the slides.
You are not able to see the slides. Let me just, okay. Let me
Ma'am, your
just share
PPT
them
is not
again.
visible.
Yeah,
Hmm?
PPT
Your
is not
PPT
visible.
is not visible, ma'am.
Okay, let me just share it again. Just give me a minute. Just give me a minute.
Yes, sure, ma'am.
Is it visible
Yes,
now?
Now
yeah,
is it visible?
it
Yes.
is.
Okay, thank you. Sorry for this small glitch. Okay, IgA nephropathy, as we know today, was first described by Berger and Hinglis way back in 1968. But prior to that, Hidong-Schönlein purpura or IgA vasculitis, as we know today, was described by Hibberdon almost 100 years back, 200 years back in 1801. And it was Hinock in 1868 who first described the GI symptoms with arthralgia, and it took almost 30 years later to describe an associated nephritis with this. In the second Chapel Hill consensus classification for the change in the nomenclature of vasculitis, which occurred in 2012, the nomenclature of Hinock-Schönlein purpura has been permanently changed to IgA vasculitis because of the role of IgA antibody in the causation of this vasculitis. If you look at the epidemiology of IgA nephropathy, it varies according to the regions. While it is the most common glomerulonephritis amongst the adult, it contributes to roughly 50% of all GN, specifically from Far East, which includes countries like Japan, Taiwan, South Korea, North Korea, etc. About 20 to 30% of GN from Europe is contributed by IgA nephropathy, and the incidence seems to be lower in the United States and amongst patients from Africa and African Americans. It is seen at all ages, but it is more common during the second and third decade, with a male predisposition of 2:3:1 as compared to females. It is more common in males. And if you look at the prevalence in the pediatric age group, there was a recent retrospective study from Kuwait on 356 biopsy specimens of glomerulonephritis in patients above the age of 12 years. The occurrence of IgA nephropathy was there in 24% of the patients. When we saw the numbers in patients less than 18 years of age, it was around 10%. In a nationwide survey of kidney biopsies over an 11-year period from China showed that the occurrence of glomerular disease amongst all biopsy-proven glomerular diseases, IgA nephropathy was responsible in children for up to 17% of these patients. And if you look at the overall data from India, the prevalence of IgA nephropathy is around 7 to 16%. These are some of the published series from India, which show a prevalence of around 8 to 16% of IgA nephropathy amongst all the biopsy done at these centers. And these include both adult as well as pediatric population, with a slightly larger number reported from western part of the country. This is a large cohort study which was published this year from SGPGI Lucknow over a 10-year period. And the overall incidence of IgA nephropathy in this particular cohort was around 11.85%. And if you look at the clinical presentation in this cohort, and this includes both adult as well as the pediatric population, and the presentation was primarily with hypertension, reduced GFR, microscopic hematuria, and only 15% of the patients presented with nephrotic syndrome. No, so what is the clinical presentation of IgA nephropathy in the pediatric population? Data from a Japanese renal registry over a 5-year period showed that in patients of IgA nephropathy, the most common clinical presentation was that of a chronic nephritic syndrome, followed by acute nephritic syndrome, recurrent or persistent hematuria, and nephrotic syndrome was reported only in 3% of the patients. In another series on 426 pediatric patients with IgA nephropathy, almost 7% had presented as nephrotic syndrome. So the most common presentation that we see in our clinical practice of IgA nephropathy is usually an episode of gross hematuria, which becomes recurrent and which is often synpharyngitic, implying that it occurs mostly during episodes of pharyngitis or during episodes of acute respiratory tract infections. But it could also present as persistent isolated microscopic hematuria or hematuria with proteinuria. If we look at the etiopathogenesis of IgA nephropathy, the most accepted model is the multi-hit pathogenesis model. It has been proposed that, and it has also been seen in clinical studies, that most of these patients are deficient. They have an IgA1 antibody, which is abnormal. Almost 90% of the circulating IgA in the sera of human sera is of IgA1 type, and this is galactose deficient in the hinge region of IgA1, and which predisposes it to being more antigenic and results in production of anti-IgA1 antibodies. So if you look at this multi-hit hypothesis, the first step of this hypothesis is that these patients are deficient. They have increased amounts of galactose deficient IgA1, and during episodes of ARI or other trigger factors, like with the infections with certain adenoviruses, certain bacteria, parainfluenza, measles, and rubella viruses, there is a trigger for production of anti-IgA1 antibodies. And once you have these circulating complexes of IgA1 and IgA1 antibodies into these sera, this is the third hit. And in the fourth hit, once these antigen antibody complexes are deposited into the kidney, specifically into the mesangium somehow has some transferrin receptors, which are which attract IgA1 antibodies more commonly. And this deposition in the mesangium leads to excessive release of cytokines, which are pro-inflammatory. Along with that, growth factors are also released, which promote fibrosis and result in glomerular and tubulointerstitial fibrosis in patients of IgA nephropathy. And this is a slowly progressive process. And for patients of IgA vasculitis, it has been proposed that genetic predisposition, that is increased amounts of ACE, IL-18 and HLA-B35 genetic genes are also associated with increased predisposition to the occurrence of IgA vasculitis nephritis. And there is a racial predisposition of IgA vasculitis, specifically more in Asians of Far East origin. Now, if you look at how do we really make a diagnosis of IgA nephropathy in these patients, the diagnosis is primarily based on biopsy because there is no clear-cut serum biomarkers which can identify patients with IgA nephropathy. And if you look at the most accepted classification of the biopsy of IgA nephropathy was proposed by the Oxford study group, where they looked at the biopsies of 265 patients suffering from IgA nephropathy recruited from almost 8 countries on 4 continents, and roughly 22.3% of these patients were children. And they studied these patients for up to a median follow-up period of 5 years. And what they found was consistently that the changes which were consistent with prognosis were primarily mesangial changes. Mesangial proliferation was in fact the most common finding in all of these biopsy specimens, followed by tubulointerstitial damage, and tubulointerstitial damage of about 10 to 20% was present consistently in almost all biopsy specimens. Apart from that, there was endothelial proliferation, and there were also segmental sclerosis in these biopsy specimens. And based on these biopsy findings, they classified this Oxford classification of IgA nephropathy as the MEST classification, where M stands for mesangial hypercellularity, E for endocapillary hypercellularity, S for segmental sclerosis, T for tubular atrophy, and later in the initial Oxford classification, crescent patients with biopsy changes of crescents were not included, but subsequently in the 2016 update, the crescents were also added as one component for prognostic indication of patients with IgA nephropathy. So now it is called the MES-C classification. And one point I want to emphasize is that all this classification is primarily based on light microscopy findings. So to make a diagnosis of IgA nephropathy, you need a light microscopy specimen and you need an immunofluorescence specimens where you can see the deposits of IgA antibody in complexes in the mesangium. Electron microscopy is not required as an essential criteria to make a diagnosis of IgA nephropathy. And if you look at, this is one of the biopsy specimens from our center. And if you can look at the components of this biopsy, it has been reported as a MEST score. And if you look carefully at this light microscopy specimen, you can see that there is a lot of mesangial proliferation. And if you can look at this vessel wall, there is a lot of medial sclerosis in this. And this is the mesochrome empty stain or mesochrome trichrome stain, where you can see a lot of tubulointerstitial damage. And when this is the IF specimen, where you can see a lot of granular IgA deposits or mesangial IgA deposits in this IF specimen, and these deposits is primarily in these mesangium of the glomeruli. And so this is how a biopsy of a patient with IgA nephropathy is usually reported, and the nepropathologist will give you a MEST score. So here the MEST score is M1, E1, S0, and T1, and this MEST score has an importance in with deciding the therapy for the patients, as well as for prognostication of these patients. And it has been shown that in the pediatric age group, we hardly find any tubulointerstitial fibrosis. The primary changes in the biopsy are due to mesangial proliferation. Hence, because of this, most of these patients are more amenable to immunosuppressive therapy, especially in the pediatric presentation of IgA nephropathy. So, are there any lab parameters which can make a diagnosis of IgA nephropathy? While serum IgA levels have been found to be increased in almost 30 to 50% of the adults, but only 8 to 16% of the children with IgA nephropathy have elevated levels of IgA. So this is not a very good parameter to make a diagnosis of IgA nephropathy. Galactose deficient IgA1 levels have been shown to be elevated in almost 90 to 95% of these patients. But again, this investigation is not available commonly in the labs. ASLO and complement 3 levels are always done to rule out a concomitant diagnosis of a post-infectious GN, which is often a close differential of patients with gross hematuria. And serum IgA to complement level seems to be a better marker or to differentiate IgA from a non-IgA glomerulonephritis. In fact, in one study, the ratio of serum IgA to C3 of more than 4.5 was associated with worse outcomes. There has been people are trying to identify any urinary or blood biomarkers which could really identify IgA nephropathy without being too invasive and using the biopsies. But well, these studies have shown that there occurs an increased urinary excretion of factors like EGF, MCP1, IL6, etc. And some proteomic data is also being evaluated for the progress of these patients. But as of now, we don't have any concrete lab parameters to make a diagnosis of IgA nephropathy. Now, coming to the management of these patients, how should these patients be managed? Well, if you look at the management protocols that were provided by Kidney Disease Improvement Global Outcome Guidelines, which were proposed for the management of chronic glomerulonephritis in 2021, they are primarily directed towards the adult population, and they have said that you can adapt these guidelines to pediatric patients as well. So the first step to make a diagnosis of IgA nephropathy is primarily to do a biopsy and classify it according to the MEST-C score. And then you risk stratify these patients using the clinical and histological data using a prediction tool. Now, this is the International IgA Nephropathy Prediction Tool, which is based on 13 criteria. And once you use this calculator, you can feed in the estimated GFR at biopsy of the patient, the systolic, diastolic blood pressures, the proteinuria at the time of biopsy, the age at biopsy, the race of the patient, and the use of ACE inhibitors, and the MES scores of the biopsy specimen, and whether the patient was on any prior immunosuppression or not. This calculator essentially has been developed using equations from a multi-ethnic international cohort of roughly 2,700 patients with biopsy-proven idiopathic IgA nephropathy, and it is designed to predict a risk of 50% decline in eGFR or ESKD after biopsy. When I filled in the data for the previous biopsy patient that I had seen in my clinical practice, I found that the risk of 50% decline in estimated GFR or progression to end-stage renal disease over a 5-year period after renal biopsy was as high as 50%. So it can really tell you the risk of progression of the renal disease at the first biopsy, but then after the treatment, this gets changed. So definitely it cannot be used for reassessment of the risk factors. Now, based on this calculator, there was an attempt to develop a similar tool for use in pediatric population, and an international cohort of almost 1,060 children with IgA nephropathy were followed up into adulthood. And what they found was that the progression of the disease was much slower in this cohort. And therefore, the endpoint had to be reduced from 50% change in GFR to 30% change in the eGFR. And based on the results of this study, they have developed a pediatric IgA nephropathy prediction tool, which can be used at the time of the first biopsy. And in this particular tool, you have 17 criteria. And in addition to the criteria that I had described previously, the gender of the child, the height and weight, and the 24 hours protein, as well as the UPUCs have been included in this particular in the prediction model. And it tells you the rate of progression of the disease, that is an estimated fall of 30% decline in estimated GFR or progression to end-stage kidney disease over a maximum period of 80 months, which translates to about 6.7 years. So how do you really treat these patients? If you look at the KDIGO guidelines, in the adults, the treatment of IgA nephropathy appears to be mild, and they say that you can use steroids for a period of 6 months. In most treatment protocols for adult patients, they tend to treat these patients for a shorter period with steroids, as they have found that many of these patients develop steroid related complications. But however, I will be discussing about the management of the pediatric patients, where the management protocol differs from that of the pediatric population. So as soon as you make a diagnosis of IgA nephropathy with proteinuria, ACE or angiotensin receptor blockers should be added immediately, and they will be continued for prolonged periods of time. There are studies where, there were studies from Japan where they found the utility of doing tonsillectomy both in adult as well as pediatric population. In fact, if you look at the guidelines of Japanese pediatric nephrology group, they say that tonsillectomy should be done for all patients with IgA nephropathy. However, while we have these guidelines from KDIGO do not recommend tonsillectomy, in fact, International Pediatric Nephrology Association, or IPNA, is also in the process of developing guidelines for treatment of IgA nephropathy and IgA vasculitis. And these guidelines will be completed by the end of this year. And in these guidelines, we have decided not to include tonsillectomy unless until there is a ENT indication for tonsillectomy. There is no need for tonsillectomy in routine cases of patients with IgA nephropathy. Apart from that, in the studies over the last 20 years in patients of IgA nephropathy, fish oil has been used in varying doses of 1 to 4 grams. And a meta-analysis on the use of fish oil does not recommend any benefit of using fish oil in these patients. There was a large RCT from China recently on the use of mycophenolate mofetil in adult population for its steroid sparing action and for using as a second line agent in patients of IgA nephropathy, and it did find some benefit of use. So the guidelines do recommend that in Chinese patients you could use MMF also in adult IgA nephropathy. And there is a study on the use of HCQS also, a recent study in use of Chinese patient with some benefit. However, if you look at the management of IgA nephropathy in the pediatric population, and this is inconsistent with the expert opinions of different groups, as well as the ongoing meetings of the IgA nephropathy guidelines proposed by IPNA, it is proposed that all children with proteinuria of more than 0.2 milligram by milligram should all be treated with ACE inhibitors and ARBs for prolonged periods of time. For proteinuria of more than 0.5 milligram by milligram or more than a gram per day, if you do a urinary 24 hours quantification, you will have to add prednisolone in doses of 2 milligram per kg per day for at least a period of 4 weeks, and which can be gradually tapered as an alternate day dosing over a prolonged periods of 9 to 12 months. In patients who present with renal dysfunction or with reduced GFR or with RPGN type of picture, in these situations, you will have to use methylprednisolone pulses in doses of 10 to 30 milligram per kg per day for at least 3 to 5 pulses, followed by oral prednisolone in doses of 2 milligram per kg per day, along with use of IV cyclophosphamide for a period of in monthly doses for a period of 6 months, as you do for all patients of presenting glomerulonephritis. And this would be followed by a maintenance phase using mycophenolate mofetil for a period of at least 18 to 24 months. There have been trials in Japanese patients, both in adult and pediatric patients in the past, where along with ACE and ARBs, they have tried using other drugs like azathioprine and mesoribin. Mesoribin is another drug which is also inhibits DNA synthesis. It is similar to azathioprine but less toxic, but however, since it is available only from a particular fungus in the area of Tokyo region from Japanese, mesoribin is not available for use in many other parts of the country. In the world rather, it is available only in Japan. And along with that, in this particular RCT, they added ACE inhibitors, azathioprine, oral prednisolone, and anticoagulants in one group versus anticoagulants and ACE inhibitors for a period of 2 years. And what they found was that there was a significant, when these patients were followed up for at least 10 years after stopping the therapy, they found that the occurrence of ESKD was lower in the group which received steroids as well as azathioprine, indicating that there is a utility of prolonging these therapies for a period of 2 years. In the recently proposed IPNA guidelines also, it has been recommended that the immunosuppression in all patients of pediatric IgA nephropathy should be continued for at least 1 year after achieving complete remission. So this could be in the range of 12 to 24 months. Some of the newer agents which have been tried in patients of IgA nephropathy, the one drug which is in a phase 3 trial is sparsentan, which is a dual-acting angiotensin 2 and endothelin type A receptor antagonist. Then in one study which was published in 2021 on the use of SGLT2 inhibitor dapagliflozin in 137 patients of IgA nephropathy randomized to Out of the 270 participants, 137 were randomized to DAPA and 133 to placebo. And after a follow-up median period of 2.1 years, the eGFR decline was definitely at least one-third lower in patients who were on DAPA. And DAPA also reduced the the proteinuria by at least 26% relative to the placebo. Then there is another study which was interesting study that I found was that this is a novel targeted release formulation of butynoside, which is primarily designed to deliver butynoside as an anti-inflammatory agent in the distal ileum, where we know that there is the large amount of Pierce patches are present in distal ileums, and the aim of this therapy is essentially to reduce localized production of IgA. And in about 150 patients, they received the drug in different doses. And they did find that, in addition to ACE inhibitors, the addition of this targeted formulation of butynoside reduced proteinuria by almost 27%. So maybe in future, we will have some localized agents which could target actually the production of localized IgA1, which could prevent the progression of CKD in these patients. If you look at the course and prognosis of IgA nephropathy in pediatric population, end-stage large series from Japan have shown that end-stage kidney disease develops in 20% of these patients after 10 years of diagnosis and in almost 30% patients after 20 years. So most of these patients will go into CKD or 4 or 5 almost 15 years after diagnosis, and therefore most of them would require some form of kidney replacement therapy only in adulthood. And the factors which are responsible for poor prognostic indicator in these patients, or the factors which will decide the progression to CKD, are the presence of heavy proteinuria, despite your using ACE inhibitors and immunosuppression, persistent hypertension, male sex, and presence of presenting glomerulonephritis, which has a higher predilection to progression to end-stage kidney disease. So now next we come to IgA vasculitis. Now IgA vasculitis is a disease that is closely linked to IgA nephropathy, and it is a small vessel vasculitis which is primarily characterized by non-thrombocytopenic purpura in almost all patients, arthritis, abdominal pain, and the renal involvement occurs in about 30 to 50% of these patients. And if you look at IgA vasculitis is more common in the pediatric age group as compared to adults, with an overall incidence of 3 to 27 cases per 100,000 school age children, with much higher up to 50 to 100 cases reported from Japan. The peak incidence of the condition is between 4 to 6 years of age with a slight male predisposition. And if you look at the renal involvement in this patient, it may not be present at the time of the onset of IgA vasculitis, but all those patients who have to develop renal involvement, it usually occurs in the first 6 months of the onset of the disease. And in most of these patients, the involvement is mild. And the most common manifestations of renal manifestations in patients of IgA vasculitis is the presence of hematuria. A low-grade proteinuria is the commonest manifestation, and a nephritic syndrome or a nephrotic syndrome will occur in less than 20% of these patients. Now, if you look at the diagnosis of IgA vasculitis, it is primarily clinical diagnosis where the presence of purpura or petechiae in the lower limb with a lower limb predominance is the mandatory criteria. And you could have at least one criteria out of the 4, that is the presence of arthralgia, presence of diffuse abdominal pain, presence of renal involvement. And generally, we tend to do biopsy is indicated only in patients who have atypical findings, especially the skin biopsy to make a diagnosis of IgA vasculitis. We tend to do in patients who have an atypical presentation, or if we find that, if there are a lot of petechiae purpura in the upper limb, so which usually doesn't happen in patients of IgA vasculitis. So here, to rule out certain other condition, we tend to do a skin biopsy, or we tend to do renal biopsies in patients who have renal involvement. And if you look at the validity of this criteria, it has 100% sensitivity to pick up IgA vasculitis with an 87% specificity. So which are the guidelines that you need to follow for the management of patients with IgA vasculitis? I think the best guidelines are your till date are available to us are the SHARE guidelines. SHARE is the acronym for Single Hub and Access Point for Pediatric Rheumatology in Europe, and it provides guidelines for management of many rheumatological conditions like GIA, lupus nephritis, dermatomyositis, and IgA vasculitis. And these were last published in 2017. And the minimum renal workup that is recommended for patients with IgA vasculitis is to look at the urine routine microscopy, to look at the urine protein creatinine ratio, and if the UPUC is elevated or if there is proteinuria, there is a point in doing a 24 hours urine examination also in the 24 hours urine protein estimation also in these patients. And the absolute indication at the time of diagnosis in these patients for renal biopsy are presence of nephrotic range proteinuria or a reduced GFR of below 90 ml. If you have mild proteinuria and that is a UPUC between 0.2 to 0.5, and if you have few RBCs and if your KFTs are normal and hypertension is also controlled, then you can wait for a biopsy for at least 2 to 4 weeks. And if you find that the proteinuria doesn't decline with ACE inhibitors, then these patients would also require biopsy eventually. So how do we classify the biopsy in patients of IgA vasculitis associated nephropathy? We don't use the MEST classification. Here we use the International Study of Kidney Disease classification in children. And this basically, if you look at these changes, most changes because IgA vasculitis is primarily an acute disease and it occurs suddenly. And because of that, most of the changes that you see in the biopsy are involving the mesangium. And if you look at the class 1 and class 2 biopsy changes, they are minimal changes with mild mesangial proliferation. And in patients of IgA vasculitis nephritis also, if you look at the IF picture, in the immunofluorescence, you will have dense IgA deposits in these patients also. And in patients who have a class 3 biopsy changes, you'll find, a lot of glomerular mesangial proliferation with there may be presence of crescents. If you have less than 50% of the crescents in the glomeruli, then you classify the disease as class 3, and this classifies for moderate nephritis. Whereas if you have more than 50% crescents on the biopsy specimens, it classifies into more severe nephritis forms, which are class 4 and class 5. And generally, tubulointerstitial changes are not present in patients of IgA vasculitis nephritis at the initial go. They may develop in the later stages, especially with the progressive lesions, but at the first time on the biopsy, primarily the changes are in the mesangium of the glomeruli. So what are the treatment recommendations for the patients of IgA vasculitis? If there is no nephritis and if there is only arthritis, abdominal pain, most of us would use some NSAIDs if they are not contraindicated with if we would use NSAIDs for these patients. And sometimes even without renal involvement, if the pain abdomen is very severe and where we have ruled out intussusception, we tend to use a short course of steroids of doses of 0.5 to 1 milligram per kg per day for a period of 2 to 4 weeks for the bowel ischemia and the bowel changes. But on the other hand, we tend to use oral corticosteroids in situations where we have mild nephritis. The recommendations for treatment of patients with IgA vasculitis nephritis are that for any degree of proteinuria, ACE inhibitors should be added. For mild disease, that is, you have class 1 or class 2 on biopsy and you have proteinuria, oral prednisolone can be used in doses of 1 to 2 milligram per kg per day. And this can be given for a period of 10 to 12 weeks, as we do for patients with nephrotic syndrome. However, in patients who show some form of crescents and who have proteinuria, significant proteinuria on examination, you need to give them oral prednisolone in higher doses of 2 milligram per kg per day. And you can also use IV methyl prednisolone as first line treatment in these patients, using the doses of methyl prednisolone as 10 to 30 milligram per kg per day, followed by, if the patient has followed by the use of IV cyclophosphamide pulses, and then later using MMF as the maintenance therapy, as you do for patients of RPGN. We are a little more aggressive. If you look at the guidelines, they say that that or moderate disease, you can wait for the use of MMF and cyclophosphamide. But in many times in our situations, because there is a very fine discrimination on biopsy between more than 50% crescents versus less than 50% crescents. So if we find some degree of crescents, which is more than 20 to 25%, we tend to treat these patients mostly as severe nephritis and tend to be a little more aggressive, because these are the patients where you can have a reversal of mesangial proliferation, and so to some extent, if your crescents are cellular in nature, you can prevent their progression from cellular to fibrocellular and fibrotic crescents and prevent the progression of chronic kidney disease. Now, if you look at these guidelines, calcineurin inhibitors and oral cyclophosphamide are not recommended for use in patients of IgA vasculitis and nephritis. And the total duration of the therapy for most of these patients would range from anywhere from 1.5 to 2 years or more. So what are the long-term outcomes of these patients with IgA vasculitis? The long-term outcomes are primarily decided by the renal involvement. In one series on children with IgA vasculitis and nephritis, out of the 122 patients that were followed up, roughly 4 or 11% patients developed CKD or died. And the estimated incidence of ESKD from two large series of IgA vasculitis associated nephropathy is around 2 to 5%. So it is a disease which has a good prognosis. However, this is a large study, which, although it is quite old, but there were 78 children with Hinox-Schönlein purpura, which were followed up for a period of almost 24 years. And what the study found was that in 44% of the patients who had presented with nephrotic syndrome or acute nephritic syndrome at presentation, eventually as adults also had hypertension or impaired renal function. And almost 82% of those who had just presented with hematuria or proteinuria were eventually normal at the last follow-up. However, in females who had pregnancies, almost 1/3 of these pregnancies, these females presented with hypertension and or proteinuria, implying the role of long-term follow-up in these patients, as these patients may develop hypertension and impaired renal functions in future. And crescents in biopsy is an important prognostic indicator. In fact, if any patient has crescents on biopsy, he has high chances of going into progressive CKD, and most of these patients would require a lifelong follow-up for the progression to chronic kidney disease. And studies have shown that the recurrence of IgA nephropathy occurs commonly both in IgA nephropathy and IgA nephropathy associated vasculitis, even in the grafts, because there is an increased predisposition to production of IgA in these patients. So coming to the end of this talk, while IgA nephropathy and IgA vasculitis seem to have good outcomes in pediatric age group, but they have a propensity to progress into adulthood. And most of these mesangial changes that we see on the biopsy studies have shown that if you give immunosuppression in the future, in the subsequent biopsies, there is a disappearance of these lesions, and there is also reduction in the amount of IgA deposits in the subsequent biopsy, indicating an important role of preventing the long-term consequences by choosing the appropriate management. And as the KDIGO guidelines do not address many issues of pediatric IgA nephropathy and IgA vasculitis, IPNA is in the process of developing guidelines for IgA nephropathy and IgA vasculitis for pediatric patients, and these most likely would be available by the end of this year or by the beginning of 2024. So I would like to thank you here for your patient hearing, and would hand over I will hand over the further this thing to Dr. Radhakrishnan. She would be discussing a case on IgA nephropathy and IgA vasculitis with you. Thank you.
Thank you, Professor Mukta, for a very differentiating, clear-cut presentation and further investigations and treatment protocol of the two disease conditions which often simulate with each other, IgA vasculitis and IgA nephropathy. You were perfectly correct that we do see more often of IgA vasculitis than nephropathy, mainly in pediatric population. And my request is that once a person encounters such patients in the periphery, they should be referred to pediatric nephrology care so that proper management can be undertaken. With these few remarks, I invite Dr. Radhika Radhakrishnan, she is Assistant Professor in Department of Pediatric Nephrology, SAT Medical College, SAT Hospital and Government Medical College, Thiruvananthapuram, for presentation of some of the case scenarios related to the topic. Dr. Radhika, please.
Thank you, sir.
Yeah.
Thank you, organizers, for inviting me for the session. It's a wonderful honor to be here today. I'm just sharing my screen. Is my screen visible?
Yes,
Yes, ma'am, your
PPT is
screen is
visible.
visible, ma'am.
Thank you. So what I would like to do over the next 20-25 minutes is to take you through different scenarios in which actual children have presented to us. And the diagnosis have turned out to be the topic of discussion today. So the first
Radhika, you're not audible.
Okay. So the first case is a 9-year-old girl. So some problem. The slides are playing. Am I audible now?
Yes, you are, and your slide is also visible. Please
Okay.
continue.
Okay, it's a 9-year-old girl who presented with history of puffiness of face and pedal edema for the last 1 week and cola-colored urine for 2 days. There's history of respiratory infection 3 to 4 days prior to the symptom onset. There's no history of frothing of urine, decreased urine output, or no history of preceding pyoderma, and the child didn't have any significant illnesses in the past. On examination, she was febrile. There was periorbital puffiness, mild pedal edema, conjunctiva was clear, throat normal, blood pressure was above 95th centile at 140-90 millimeters of mercury. Growth and development was normal. System examination normal. No deformities, no scars. On lab evaluation, hemogram and peripheral smear was normal. Urine was cola-colored. Urine showed 2+ proteinuria. There was numerous RBCs, red cell counts, then granular counts, and there was some pyuria also. Serum albumin was normal. Serum cholesterol was normal. The renal function tests were within normal limits with a GFR of 81 ml per minute per 1.73 meters square. She had subnephrotic proteinuria with a urine protein creatinine ratio of 0.8. So what is the clinical syndrome that we are having here? So we have a patient who is having hematuria, proteinuria, and hypertension. So this is typical of what we will term as acute nephrotic syndrome, which we consider as an acute, self-limiting, reversible illness in most cases. So what are the differential diagnoses of acute glomerulonephritis in children? It could be infection-associated glomerulonephritis. Of this, the most common is post-streptococcal. Other infections like bacterial, especially staphylococcal infection, viral, fungal, rickettsial, and spirochetal infections can cause this. We also have to remember that it can be concurrent with other infections like subacute bacterial endocarditis and shunt nephritis. It could be also a first presentation of chronic glomerulonephritis like IgA nephropathy, NK vasculitis, membranoproliferative glomerulonephritis, Alport syndrome, and FSGS, and also a rare disease which is known as C3 glomerulonephritis. So we saw IRGN, we are seeing chronic glomerulonephritis. In addition, it could always also be a secondary glomerulonephritis in which the kidneys are involved along with the systemic diseases like the IgA vasculitis that we just heard about, SLE, and other diseases. But our child has a history of respiratory infection 3 to 4 days prior to the onset of symptoms. So do we think that it is a PSGN? So in other words, what is the temporal relationship between infection and development of hematuria in PSGN? So usually the latency between the streptococcal infection and the onset of clinical syndromes usually varies from 3 to 33 days. On an average, the latent period is 7 to 14 days for sore throat and 2 to 4 weeks for pyoderma. So in our case, since the latent period is too short, it is unlikely that it is a PSGN. So how do we test? What are the tests that we should do when we see a glomerular nephritis? We should do a CBC, a urine analysis, serum creatinine, albumin, cholesterol, complement C3, serology of streptococcal infection ANA, and kidney ultrasound. So what we did in our child, the serum C3 was found to be normal, ANA was negative, the ASO titer was also normal. Ultrasound revealed bilateral hyperechoic kidneys which were normal sized. So what is the significance of these infections? So basically what we want to know is the role of complement in the evaluation of glomerular nephritis. Complement is one of the most important infections in GN. Based on serum C3, we can divide GN into a low C3 GN, which includes infection-related glomerular nephritis, SLE nephritis, MPGN, or membranoproliferative GN, C3 glomerular nephritis. A normal C3 is found in IgA nephritis and vasculitis, Alport syndrome, and thin basement membrane disease. So now the question is, this is a child with acute GN with normal C3. Does she require a renal biopsy or a kidney biopsy? So let's see the indications of kidney biopsy in acute nephrotic syndrome. So basically you can classify it into two. One is the atypical presentation and second is delayed resolution. So the atypical presentations will include anuric AKI, rapidly progressive renal failure, nephritic nephrotic syndrome, systemic manifestations, presence of normal C3 at presentation, and recurrent hematuria. So what does delayed resolution mean? To know what is delayed resolution, we need to know the natural evolution in IRGN. So irreversible kidney failure is a rare occurrence in children and resolution is usually quick. Plasma creatinine usually returns to normal by 3 to 4 weeks. Gross hematuria usually resolves by 2 to 3 weeks. Hypertension by 2 to 4 weeks. And complement normalizes by 6 to 8 weeks. Proteinuria can take up to 6 months for resolution, whereas microhematuria can take even longer, that is around 6 to 12 months. So anything which is not within this time frame can be considered as delayed resolution and can become an indication for kidney biopsy. So we did a biopsy in our child, and what did it show? It showed 26 glomeruli, non-obsolescence, and the glomeruli appeared normal in size with diffuse moderate mesangial hypercellularity, and there were crescents in only 2 glomeruli, that is 7%. There's no endocapillary proliferation or segmental sclerosis. Tubules showed some epithelial vacuolation and 5% of interstitial fibrosis. IF was 3+ positive for IgA. So the diagnosis was IgA nephropathy with an Oxford 2017 classification showing M1, E0, S0, T0, and C1. So with this we have just heard. What do we do to treat? If there is only proteinuria, you need only supportive therapy, which is using an AC inhibitor or ARB, and to reduce the BP to less than 50th centile. Whereas if the child is at high risk for progressive disease, you need to use glucocorticoids along with supportive therapy, and MMF can be used as an alternative to steroids. So for our patients, we started her on losartan 25 milligram once a day and titrated it to 50 milligram once a day. And she required also amlodipine for blood pressure control. At 6 months follow-up, her blood pressure was at less than 50th centile. She has persistent microscopic hematuria, which is sort of expected, but the urine protein creatinine ratio is well within control and varies from 0.3 to 0.6. So when we look at the poor prognostic factors, our child currently does not have any poor prognostic factors like heavy proteinuria, persistent hypertension, or reduced GFR at presentation. She didn't have much diffuse mesangial proliferation or any crescents or sclerosis or capsular adhesions. She had only 5% IFTA, and we have not done an EM for this child. But if we see subepithelial electron dense deposits or GBM lysis, it again becomes a poor prognostic factor. So next case is a 12-year-old boy who has history of intermittent gross hematuria for the last 1.5 years, which again was precipitated by respiratory infection. So each of these episodes were typically precipitated by respiratory infections. And once he has hematuria, the gross hematuria lasts for 2 to 3 days, followed by a period of microscopic hematuria and 1+ to 2+ proteinuria lasting 1 to 2 weeks. There's no history of edema, frothing of urine, graveluria, passage of stones, or abdominal pain. Eye and ear evaluation was already done and was normal. On examination, so this was basically done to rule out Alport syndrome. So on evaluation, he has no edema, blood pressure is only 90 upon 60 millimeters of mercury, and system examinations were within normal limits. So basically what we are dealing here is recurrent hematuria. So when we ever see a recurrent hematuria, we have to think of two causes. One is glomerular and the second is non-glomerular. So glomerular causes includes IgA nephropathy, benign familial hematuria, Alport syndrome. The non-glomerular causes is basically nephrolithiasis and hypercalciuria, so the stones, then tumors, tuberculosis, and even though supposed to be rare in children, we still do come across, and it's a disease, it's a diagnosis by exclusion, which is Munchausen's disease or Munchausen's by proxy. So in this child, the lab evaluation, hemogram and peripheral smear was normal, urine was cola colored, and it showed 2+ proteinuria, numerous RBCs. Serum albumin was 3.8 gram, cholesterol, RFT was within normal limits, GFR was 92 ml per minute on 1.73 meters square, and the urine protein creatinine ratio was 1.2. So he is having subnephrotic proteinuria. Again, a kidney biopsy was done because this is a child with recurrent hematuria. So we got 43 glomeruli, which revealed diffuse mesangial hypercellularity, segmental sclerosis in 6 glomeruli, and cellular crescents in 2. There was no endocapillary proliferation. IF showed 8 glomeruli, which revealed mesangial and capillary walls 3+ IgA. So again, we are dealing with IgA nephropathy with a mesh score of M1, E0, S1, T0, and C1. So the next case is a 15-year-old boy, 9th grade student and dancer. He presented with history of, puffiness of face and pedal edema for the last 2 days and cola-colored urine for 2 days. He has history of sore throat 7 days prior to the symptom onset. There was no history of decreased urine output, no history of preceding pyoderma, no history of excessive physical exertion recently, no history of any significant illnesses in the past. Interestingly, his elder brother had a history of PSGN, which was biopsy proven since he presented with AKI 2 years back. On examination, he had mild pedal edema, blood pressure was 110 upon 70 millimeters of mercury, which was less than the 95th centile. On evaluation, urine showed 3+ albumin, RBC is 40 to 45, and WBC is 10 to 15 upon hyperfill. Renal function test, the RFT was 55 upon 0.8 milligram per deciliter. The GFR was 80 ml per minute per 1.73 meters square. Serum albumin was only 1.9. Serum cholesterol was raised at 737 milligram per deciliter. And he had a 24-hour urine protein of 4.65 grams per day, clearly a nephrotic range proteinuria. So now what we are having is a nephrotic syndrome. He's having nephritic features as well as nephrotic syndrome. So it's a nephrotic syndrome. So this again became an indication for kidney biopsy, which we did. It showed only 9 glomeruli, which were but normal in size and cellularity. There was absolutely no endocapillary proliferation, mesangial sclerosis, crescents, and the tubules and interstitium were unremarkable. On immunofluorescence, he had, so with this, it would have been any minimal change disease, but the IF showed 2+ IgA. So now the differential diagnosis becomes, is it a minimal change disease with mesangial IgA, or is it an evolving IgA nephropathy? So this was the exact diagnosis that the pathologist actually gave us. We also sent a sample for electron microscopy, which the report obviously was a bit delayed, but it came as diffuse effacement of visceral epithelial cell foot processes and occasional mesangial electron dense deposits. So actually, there's an entity known as IgA nephropathy with apparent minimal change disease, in which the child usually presents with acute onset of nephrotic syndrome with only mild mesangial proliferation on kidney biopsy And the most prominent finding is diffuse food process effacement. So you could see that this is typically how our patient presented. He presented with an acute nephrotic syndrome. The light microscopy showed only mesangial proliferation, but the IF shows IgA 2+. And electron microscopy shows diffuse food process effacement and some electron-dense immunoglobulin deposits. This is an entity which is more frequent in children. The exact mechanism is not understood. Some think that it is a chance occurrence of IgA deposits in a minimal change disease, but it's probably unlikely. And the important thing here is it should be treated similar to primary MCD. So whereas we usually think whether to give immunosuppression in IgA nephropathy, if it presents an MCD, there is no doubt you have to give steroids like you would treat a minimal change nephrotic syndrome. So we started this child on prednisolone 60 milligram once a day with losartan 25 milligram once a day. At 4 weeks, the urine albumin was nil, RBCs was 5 to 8 per high power field. The PC ratio had come down to 0.6. Renal function tests had improved. Serum cholesterol was coming down, serum albumin had improved. At 6 weeks, urine analysis again showed persistent microscopic hematuria, but the protein creatinine ratio was 0.2. Serum cholesterol again had come down and serum albumin had normalized. So this is typically a remission of nephrotic syndrome. And at the end of 6 weeks, like we would do for minimal changes or idiopathic nephrotic syndrome, the patient was started on 40 milligram of prednisolone on alternate days. But 3 weeks later, this child again presented with dizziness and diplopia. On examination, he had bilateral pedal edema. A blood pressure was still normal. He had bilateral lateral rectus palsy, and urine showed albumin 3+ along with hematuria. Protein creatinine ratio had risen up to 7.8. Serum cholesterol had gone up and serum albumin had dropped to 1.7 grams per liter. So because he had lateral rectus nerve palsy, we did an MRI plus MRV of the brain, and it showed thrombosis in the superior sagittal, right transverse, and right sigmoid sinus. So this child is again typically presenting like a minimal change disease or an idiopathic nephrotic syndrome with cerebral venous thrombosis. The mechanism of thrombosis in IgA nephropathy, though it's a rare occurrence, has been studied, and venous thrombosis is mainly due to aggregation of fibrin and RBCs, whereas arterial thrombosis is basically platelets and with small amounts of fibrin. And like other nephrotic syndromes, venous thrombosis is more common. Vascular endothelial cell damage, hypercoagulable state, and hemodynamic changes, like in other nephrotic syndrome, promote thrombosis in IgA nephritis as well. In addition to this, immune complexes and autoantibodies in patients with anti-IgA nephropathy will directly cause vascular endothelial damage, leading to the subendothelial collagen exposure and activation of coagulation pathways. So in this child, again, we treated the child like we would do for a idiopathic nephrotic syndrome who is in relapse and presenting with thrombosis. His prednisolone dose was increased back to 60 milligram per day. He was started on injection enoxaparin followed by warfarin. After 1 week, he had improvement in diplopia and bilateral lateral rectus nerve palsy, which completely recovered by 2 weeks. After 4 weeks, he had attained partial remission with the PC ratio coming down to 2.2. But since he had only attained partial remission, we added the second line drug, which is MMF at 1200 milligram per meter square. Currently, he's on steroid taper along with MMF and warfarin. He is still having a protein creatinine ratio of 1. Serum albumin has normalized and cholesterol has come down. And we are keeping his target INR in a range of 2 to 3. So this is my last case. He's a 5-year-old boy who is presented with history of rashes on legs and swelling of legs for 5 days. He has intermittent abdominal pain for the last 3 days. There is a history of respiratory infection 3 to 4 days prior to the symptom onset. There's no history of joint pain, swellings, discoloration or frothing of urine, decreased urine output, or no significant illnesses in the past. So this is the child. You can see the typical rashes. He was febrile. He had mild pedal edema and palpable purpura over both gluteal region as well as lower limbs, and some of the lesions appeared excoriated. Conjunctiva were clear, throat was normal, blood pressure was normal, other system examination was normal, there was no joint swelling or restriction of movement or tenderness. The lab evaluation revealed a hemoglobin of 11.2, platelets of 5.2 lakhs, a slight thrombocytosis. Urine analysis was normal. Urine PC ratio was nil. Albumin, cholesterol, kidney function test, everything were within normal limits as per the coagulation profile. So the diagnosis is pretty straightforward. This is a case of Henoch-Schönlein purpura, or the current terminology, as we say, is IgA vasculitis. So he was started on supportive management. After 5 days, the mother, he was hospitalized actually. So after 5 days, mother complained of a high colored urine, and the urine showed 2+ proteinuria with RBCs of 20 to 30 per high power field. A 24-hour urine protein of 420 milligram per day, which came around 24 milligram per meter square per hour. Serum albumin, cholesterol, and KFT were still within normal limits. So what has happened? The child has gone on to develop nephritis now. So as Mukta ma'am said, it is a common complication in HSP and can occur in 20 to 54%. And the most important, it is the most important chronic complication of HSP and the most important prognostic factor as well. As we saw, hematuria with no or mild proteinuria is the most common presentation, but 20% of these children can develop nephritic or nephrotic syndrome. And kidney involvement can occur up to 6 months after the onset of HSP. Another important thing is active kidney disease can develop after initially mild HSN or many years after stable minor urinary abnormalities. And we saw that kidney biopsy will be identical to IgA nephropathy, but the severity of renal histological abnormalities will correlate with the long-term kidney outcome. So this was the ISKD-C classification of HSP nephritis that we just saw. So grade 1 and 2 is mild, 3 is moderate, 4, 5, and 6 will be classified as severe grades of nephritis. So now the question is, okay, we know that there is a classification system and all, but does this child require kidney biopsy? The answer is no, because it's done only if the diagnosis is uncertain or if the child has severe proteinuria or impaired kidney function to assess for the severity of the lesions, especially the presence of crescents. Mostly the diagnosis is clinical. So in our case, the diagnosis was straightforward. He didn't have any significant disease. He just had mild proteinuria. So we will just wait and watch. So next question is, this child when we admitted did not have any renal involvement. So could we have prevented nephritis in IgA vasculitis by starting steroids? Again, the answer is a big no. This is a study, which is a reasonably big study enrolling more than 350 children. And it has proven that there is no role for prednisolone to prevent proteinuria or hematuria in children with HSP. So this Mukta ma'am has already covered how to treat IgA vasculitis with nephritis. I will just put it in 2 sentences. One is, if we have only limited renal involvement, that is only hematuria or proteinuria less than 1 gram per day with a normal creatinine, we have to just monitor. But if you have a higher proteinuria or renal impairment, you have to do a renal biopsy and start immunosuppression. Just a word about following these children up. If this child had only an initially normal urine, we had to do a urine dipstick at least once a week for 2 months and then once a week for 4 months. So that means we are following them up at least for 6 weeks. If the child has isolated hematuria with non-nephrotic proteinuria persisting after 6 months, we have to monitor the protein excretion monthly and serum creatinine every 3 to 6 months till it resolves. If there is only isolated hematuria with no proteinuria, there's no need for even kidney function monitoring. And the prognosis also we have just seen, it has excellent kidney prognosis. Only if you have older age, nephrotic proteinuria or raised creatinine or hypertension, you can think of poor prognostic factors. But if you have nephritic or nephrotic syndrome, the long-term renal impairment is seen in 33 to 44%. The most important factor in biopsy is to look for the percentage of presence. So in our index case, the skin lesions and the abdominal pain improved with conservative treatments. There was no microscopic hematuria and proteinuria at 2 months. There were no disease relapses. And at 1 year follow-up, he continues to do well with no hypertension, no hematuria, and no proteinuria. So these were the cases that I wanted to discuss. Thank you all for your patient listening.
Thank you, Dr. Radhika, for excellent 4 cases presentation with different manifestations of 2 diseases. So Dr. Jiten, we have some time. Professor Bagga sir has also joined. So good evening, sir, and I would like to have your viewpoints and comments on these 2 topics. Professor Bagga sir. Okay. Dr. Aditi.
So I think maybe there's some internet issue at his end. He
Yeah,
was
it
there
may be
before.
problem. So
Yeah.
you can, I'm not seeing sir connected, maybe some internet issue. So I request you to have your valuable opinion on these 2 topics, closely related topics, and the 4 case presentation. And thereafter, then we will hand over the mic to Dr. Jiten. In question answer chat box, I'm not seeing any questions. So one of the DNB NEfPRO student has requested to have some handouts, but we will present with the slides. So Dr. Aditi, please.
So thank you. So actually, we would definitely, as Dr. Mukta also highlighted, compared to the KDIGO policy of management, our management for pediatric cases would be more aggressive and more so in IgA vasculitis, which is a vasculitic process, more inflammation, and there is aggression definitely in managing these patients more than our adult colleagues would agree to. So we would be using immunosuppression more often than our adult colleagues would for both indications, both IgA nephropathy and IgA vasculitis. Despite the similarity of name, definitely when there is nephritis in IgA vasculitis, we are more worried in terms of need to manage immediately and are concerned if there is persisting proteinuria or impaired renal function. Very often this aggression would be similar to sometimes when we manage say rapidly progressive glomerulonephritis, because these patients could have difficult outlook, especially the nephritis is severe. On another, I mean, we hope that we would have better guidance when we get the KDIGO group to, when we have the IPNA guidelines, because this would be a group of pediatric nephrologists. And I'm sure that there'll be differences from the KDIGO outlook on this, even as Dr. Mukta has highlighted throughout her talk about the differences in policy of management. With that, I would just request you in the interest of time, so there are maybe 4 question answers on the chat window.
Yeah.
And should we
Yeah,
take
you
them?
can conduct the question answer session. Yeah.
Okay, sir. So,
You go ahead with the question answer.
okay, sir.
And I
So,
request Dr. Mukta to respond. Yeah.
Yeah, so there are some questions,
So
Dr.
there were
Radhika,
some
regarding.
questions which I've tried to answer in the chat box
Yeah,
as
Dr.
well.
Mukta, yes, ma'am.
Yeah, there were some
Yes, ma'am.
questions related to the total dose of steroids being used in these patients. So we said that in ceiling doses in pediatric age group would be 60 mg as we do for nephrotic syndrome. Then the other questions have been on the role of complement C3 in patients of IgA nephropathy. Complement cascade is not commonly involved in patients of IgA nephropathy. And if you look at the biopsy specimens also, complement is very minimally there in the biopsy, and it may be absent also. So that is why the role of C3 measurement is essentially to rule out PIGN rather than, making a diagnosis of IgA nephropathy. So I think these were 2 or 3 questions. And one had asked with how soon we should start monitoring for proteinuria in a diagnosed case of HSP or IgA vasculitis. Almost immediately. When you make a diagnosis of IgAV, please do a urine protein and keep monitoring this child for renal involvement even up to 1 year, because renal involvement has been shown to mostly occur in 90% till about 6 months, but can occur up to 12 months also. So the guidelines, both KDIGO as well as the IPNA guidelines, which will be published, recommend that these patients should be monitored for 12 months for the involvement of kidney renal involvement. And many times I've seen in clinical practice, that there may be a recurrence of the rash, and whenever there is a recurrence of rash, there are more chances of renal involvement. So especially in patients where you find recurrence of rash in patients of IgA vasculitis, these are the patients whom you should closely monitor for renal functions also, because there are fair chances of and more severe involvement of renal involvement in these patients.
One question was there, Dr. Muktak, is
Yeah.
do all patients of IgA vasculitis need renal biopsy?
I think Dr. Radhika had also answered that question, that all patients of IgA vasculitis, if they present with nephrotic syndrome at the first go, or if the KFTs are altered, or if there is a GFR of less than 90 ml, then you should do the biopsy immediately. And this is consistent with SHARE guidelines and the guidelines which are to be proposed by IPNO also. But if the proteinuria is less than, UPUC is less than 0.5 milligram by milligram, then in that situation, if the UPUCs are between 0.2 to 0.5, you can start ACE inhibitors and wait for a period of 2 to 4 weeks. Because the tendency of the vasculitis would be to heal over a period of time. So if this healing is achieved within 2 to 4 weeks, you may not do a biopsy. But yes, if you have significant proteinuria after 4 weeks also, then in that situations, you will need to do a biopsy.
Dr. Aditi, please.
I think we would broadly agree with Dr. Gupta. I mean, overall, but I mean, with any measure of proteinuria, we are more inclined to biopsy than not, particularly if it's persisting on
Yes,
2 or 3
I think our
occasions.
threshold for
Yeah.
biopsy is more than what has been defined by the guidelines. Yes.
Yeah. So there are no more questions in that.
Jitendra, would you want to comment on the immunosuppression from our unit protocol perspective?
No, I think we don't have time. We can proceed with the quiz.
So
Sure.
Hello. Hello.
Hello, sir. Am I audible?
Yeah, sure. Go on to the post test. Yeah.
Okay. Okay, sir. So I'm launching the first question. Is it visible?
Yes, it's visible.
Okay. 15 seconds. Thirty seconds completed. Moving to the next question. Ten seconds. $20 seconds. Last 5 seconds. Thank you. Moving to the next question. $20 seconds more. $10 seconds more. Thank you. Moving to the next question. $15 seconds more. Thank you. Moving to the next question. 10 seconds. 20 seconds. 30 seconds. Thank you. Moving to the next question. Fifteen seconds more. Thank you. Moving to the next question. Twenty seconds left. 10 seconds left. Thank you so much. Moving to the next question. Ten. 20 seconds. 30 seconds. Thank you. Moving to the next question.
Sure.
15 seconds more. Thank you. Moving to the next question and the last question. Twenty seconds more. 10 seconds more. 30 seconds. So no polls left, sir. Thank you so much.
Yeah, Dr. Jiten. Yeah.
Yes,
So
yes.
can we conclude?
Yeah, so just
Okay. So with this presentation, very interesting presentation on two related topics in pediatric nephrology. And there are two speakers, Professor Mukta and Dr. Radhika. We thank both of them. And of course, the executive committee of the ISPN, the nodal coordinator, Dr. Jiten Meena, assistant professor from AIIMS New Delhi, and of course, our president, Professor Susan Uthup, and secretary, Dr. Aditi Sinha, duly supported by our senior, very senior faculty member, Professor Bagga, Professor Hari, and others, that we are conducting weekly this program. So we thank all of you, and of course the audience attendees, who about 150 odds were there, and a good number who connected with this for this webinar. And see you next Friday. With these few words, thank you very much to all. Good night. Good night to all.
Thank you so much, all.
Thank you, everyone.
Thank
you.
you, sir.
Okay. Thank
Good
you,
night,
Sana.
sir.
Good night. Yeah. Dr. Jiten, you want to say something?
Yeah. So for participants, I have shared the answer key in the chat box. Please look at this. And our next webinar will be on next Friday on Acute approach to acute glomerulonephritis.
Nephritis, very common topic, mainly for the use postgraduate students and fellows.
So with that,
Okay.
Thank you everyone for joining us today.
Thank you. Thank you very much. Thank you.
Thank you
Good
so
night.
much, all.
Thank you.
Thank you. Thank you, all of you. Thank you.
Thank you. Thank you, speakers. Thank you.